So we're coming to, in the next section is three free papers again. The first presenter is Narushka Naidu. You can come up to the podium.
Good morning, everyone. I'm Narushka Naidu. I'm a surgical registrar at Stellenbosch University. I'd like to thank Begosa for this opportunity to present this. And this abstract is a part of my MMed, multidisciplinary breast cancer multidisciplinary team meetings. Are patients receiving the treatment recommended? It's not doing on the front. Yeah. The slides are changing on this projector, but not on the part I can see.
The speaker
There we
screen
go.
is not. Oh, there we go.
Okay, so in general, the purpose of the MDT meeting is to discuss an individual treatment plan and follow-up for the patient, as well as to discuss the overall care of the patient. Here we see the well-described benefits of the MDT meeting to the breast cancer patient, and whilst they should form part of the gold standard of the care for the patient, they sometimes are not. We found a gap in the South African literature exploring the benefits of the MDT meeting to the breast cancer patient, and this became the rationale behind our study. However, to truly assess if the MDT meeting was beneficial to the patient, you would have to first assess the concordance and ensure that the treatment the patient received was aligning with that was recommended, and this was our aim. These are some of the well-described barriers to having an MDT meeting, and best described on a system, physician, and patient level. On a system level, it seems to be problems with infrastructure and resources. On a physician level, a lack of leadership, a lack of motivation, and an increased workload. And on a patient level, fragmented services. In Tygerberg, we have a clear protocol on how to run the MDT meeting with a clearly assigned leader. As you can see here, we are the central hub to our referral hospitals. That includes Vista Hospital, Paarl Hospital, Karl Bremer Hospital, Khayelitsha District Hospital, and Easter Riviera Hospital. Most of these hospitals are secondary level hospitals, however, some of them are district level hospitals. So who should be included in the MDT meeting? It has been suggested that there should be a surgeon, a pathologist, an oncologist, a radiologist, and a nursing practitioner. In Tygerberg, we have a separate radiology meeting, so they don't attend our MDT meeting. We use it as a teaching tool, so our registrars and medical officers, as well as our interns, present the patients, and our medical students attend the MDT meeting, usually online. We record everything on an electronic database, and we discuss 40 to 50 patients a week, including our post-operative patients. Since COVID-19, it's performed in a hybrid setting that is both online and in person, and this addresses the barrier on an infrastructure level. Being used as a teaching tool, this tends to encourage motivation amongst the physicians, and it's designed in a way so as not to add to their workload. Our study was a retrospective cohort descriptive study. We looked at patients that were discussed in our MDT over a 1-year period of time. We started with a sample size of 614 patients, and then excluded the patients that were presenting with recurrence, had incomplete data, or were for palliative care, and it gave us an impressive sample size of 556 patients. Our main database was CloudVein, and we also correlated with NHLS and TrackCare. As you can see here, these were our results, and we found the highest concordance in our surgery group. So this was 94% of the patients that were recommended for upfront surgery received a treatment that aligned with that which was recommended. This was followed by 91% in the group for endocrine treatment and 88% in the chemotherapy group. We found our lowest concordance of 60% in those that had a requirement of more than one therapy. And in general, these patients tended to have a higher stage of breast cancer. It gave us an overall concordance of 88%. As you can see here, as expected, we found that the rate of discordance increased with the increasing stage of breast cancer, and it was just 77% concordance in stage 4. Whilst we did not explore the reasons for discordance, there was a study performed at Stellenbosch University previously by Kepke et al. It was a qualitative study, and they explored the barriers and facilitators to chemotherapy adherence. They conducted interviews between doctors and nurses and found that they were best described on an individual or structural level. On an individual level, the facilitators they found was self-motivation from the patient themselves and a good support system consisting of the patient's family and friends, whereas the barriers was a limited knowledge and understanding from the breast cancer patient. On a structural level, they found issues with transport and finances to be the barrier to receiving chemotherapy. These are some of the international studies that were performed. As you can see, in Bristol in the UK, they had a participant number of 210 patients with a concordance of 93%. That was in 2012. The study by Rajan in 2013 took place over a number of years, I think 4 years, and they had 750 patients with a concordance of 91.5%. And then in Perth, over 4 years, 925 patients. And then in the Netherlands in the year 2022, 118 patients that, particularly breast cancer patients, with a concordance of 85%. So if you look at this and see that in 1 year, our sample size was 556 patients with a concordance of 88%, that tends to be really impressive. We were very happy that our results tend to align with that of international studies. We find that it is an impressive concordance if you think of our restricted resources. And there was a clear patient benefit. If you think of a patient referred from the outskirts to Worcester Hospital, who then manages to receive chemo and radiotherapy, this is really an impressive improvement in service delivery. There's also a decreased variance in the treatment of the different breast cancer patients, and we've managed to address the barriers in having an MDT, and it tends to run quite smoothly and efficiently, and we thus recommend that MDT meetings form part of the treatment for breast cancer patients. And whilst we did not explore the reasons for discordance, we found that the most common documented reason was the patient's choice. These are my references. Thank you so much.
Thank you very much, Narushka. Maybe if there's one question we'll take one question per each one of these papers. Yeah, if there's no, my feeling is from our side as well, our patients really struggle with transport. That's one of our biggest stumbling blocks in this country. I don't know in the other provinces, but in Western Cape, our patients are really struggling, especially from the rural areas. There just isn't enough hospital transport available for these patients, and that's why they often don't get to the recommended treatments.
Yeah, we also have a fund where we particularly address the transport for the breast cancer patients. Thank you.
Maybe if I can just mention, I think transport in Johannesburg is also quite an issue. And even in Gauteng, which is quite a small province, patients are not that far, that rural. We find that it's a huge cost that they have to sort of be compliant, yet they don't have the funds to do so. And there, I think, sort of Cancer Alliance and there's various sort of patient advocacy groups that have really come to the party, I must say, and I have to commend them to provide funding to provide novel ways of engaging with taxi associations to provide transport for our patients, and even for patients who are quite infirm, needing wheelchair, where they actually come to the party with Uber trips. So there's some novel ways, and I must really compliment patient advocacy for coming to the party and helping our patients.